Our subject today about the menopause. The menopause is defined as the woman's final menstrual period and accepted from confirmation of this is made retrospectively after 1 year of amenorrhoea. And the cause of menopause is cessation of regular ovarian function. Perimenopause or climacteric phase is time of the life from the onset of ovarian dysfunction until 1 year after last period and the diagnosis of menopause was made. This time is known as climacteric. Postmenopausal, all women who have been 1 year since their last period are deemed postmenopausal. The average age of menopause is median age between 51 and 52 years, with 95% of women attain menopause between the age of 45 to 55 years. Endocrine changes or reproduction function is maintained by a subtle interplay of the hypothalamus production of gonadotropin releasing hormone GnRH, the pituitary hormone LH, and FSH, the ovarian peptide hormone inhibin B, and the steroid hormone estrogen, progesterone, and testosterone. These all affected, and inhibin B is produced by follicle within the ovary, so the number of the follicle decline and the production of inhibin decrease, increase in pulsatility of the GnRH secretion and overall serum FSH will result in increased drive to the remaining follicle in an attempt to maintain follicle production, and estrogen level may be decreased in this period. So, androgenic hormone produced come from the ovary, peripheral adipose tissue, and adrenal gland, with the ovary producing approximately 30 to 50 of total circulating level. A decline in ovarian testosterone and the other androgenic accompany the process of aging in women was occur. Diagnosis is dependent on large clinical diagnosis and made according to symptom experience such as menstrual irregularity and amenorrhoea, and estrogen deficiency symptoms such as autoflash vasomotor symptom. The use of serum endocrine tests such as hormone level are of little value in the perimenopausal year, as they are unpredictable due to hormonal variation, and that frequently occur association with episode and irregular ovulatory cycle at this time of life. In all women in whom a diagnosis of menopause is being considerable, the possibility of pregnancy should also be considered. Why? Because the GnRH high elevated. Then physiological menopause, premature ovarian insufficiency. If menopause occurs before the age of 40 years, it is defined as premature ovarian insufficiency. It is also sometimes called premature ovarian failure or premature menopause. It is thought to occur in approximately 1% of women under 40 years and 0.1 under 30 years. The most common cause of ovarian insufficiency or premature ovarian insufficiency due to counseling, delivery, and specialist treatment, and ensure that they are fully understand their condition. Most common cause primary and secondary. Primary chromosomal, autosomal, enzyme deficiency, secondary chemotherapy, radiation, drug use. Iatrogenic menopause, another type of menopause, is GnRH is given in a constant high dose. It desensitizes the GnRH receptor and reduces LH and FSH release. Drugs that use against such as GnRH agonists like pozarline and gozarline can be used as in the treatment for women complaining of endometriosis uterine fibroid, and other gynecological problems when administration continuously, and they will down-regulate the pituitary and consequent decrease release of LH and FSH. This will induce temporary menopause with a highly relative rapid onset and can be managed. With this introduction of the hormone therapies and other drugs to relieve some of the unwanted menopausal symptoms and known as back therapy. Another type of menopause, surgical. Women may be placed into surgical menopause aiming to permanently treat it, being gynecological conditions such as menstrual disorder, fibroid, endometriosis, bilateral salpingo-oophorectomy. Bilateral salpingo-oophorectomy may also be performed prophylactic for women at high risk for inherited malignancies such as breast or ovarian cancer or BRCA1 gene and 2 mutation secret. How women are affected by menopause. Side effects of menopause or clinical presentation and signs symptoms. Vasomotor symptom. The exact etiology of vasomotor symptom is unknown, but it is thought to be loss of modulating effect of estrogen on serotoninergic receptor within the thermoregulator center in the brain. So hot flash occur in 80% of women and 30% of patients seek help. Psychological symptoms: irritability, lack of energy, low mood, tiredness, and impaired quality of life from early perimenopausal period. Cognitive function. No clear evidence that menopause is associated with acceleration of the onset of incidence of dementia. Endometrial effect. Initial irregularities, vaginal bleeding, and is due to reduction of estrogen, endometrial stimulation, and filling of ovarian function, ultimately resulting in period complete stopping when the endometrium is no longer stimulated. The urogenital tract and vulvovaginal atrophy. Once estrogen level is start to fall in perimenopausal women, they may become aware of vaginal dryness, irritation, burning, soreness, and dyspareunia and recurrent infection. Bone health. One of the best understood area to long-term post-reproductive health is the change in bone that occur in loss of estrogen support of skeletal metabolism. Bone density naturally increases during childhood, reaching peak at 20 to 30 years, and after 60 years, the likelihood of osteoporotic fracture of the hip and spinal bone may occur. Osteoporosis is defined as a skeletal disorder characterized by compromised bone strength, predisposing to increased risk of fracture. It is more frequent in women than men, with an approximate ratio of 4:1. Risk factor for osteoporosis: family history, smoking, alcohol, doctor, steroid, and premature ovarian insufficiency, medical treatment, disorder of gut absorption, thyroid, parathyroid. Cardiovascular system. During the menopause transition, there are several changes in the female physiology that can influence individual risk of cardiovascular disease. These include lifestyle issues such as nutrition, exercise, changes in the disturbance in the fat, and change in the serum lipid level. Estrogen also has a supportive effect on the vessel's wall, and that favor vasodilatation and prevent atherogenesis and effects that are reduced after menopause. Management, diet and lifestyle. Extensive evidence exists to support improved longevity and with regular exercise, stopping smoking, reduce alcohol consumption. Non-hormonal prescription treatment such as local symptomatic treatments such as dryness of the vagina, moisture, lubricant, for vaginal dryness, and bisphosphonate and aloxifene and terbutaline is also indicated in some patients have begun to osteoporosis. And another non-hormonal treatment, alpha-adrenergic agonist, beta blocker, modulator, fluoxetine, paroxetine, gabapentin. These support the hot flash, psychological condition, and other conditions. Hormonal replacement therapy, HRT, either estrogen or combination, and the role of taking estrogen is either oral, vaginal, or systematic, according to the present or absent of the uterus. If estrogen is given without progesterone opposition, there is a risk of endometrial hyperplasia and cancer may develop. Systemic estrogen only HRT is suitable for men who no longer have a uterus following a hysterectomy. Estrogen and progesterone for those seeking for a cycle or not had a hysterectomy and for a short period and have a cycle and monthly administrated and suitable for women during the perimenopausal or early postmenopausal years. Administration of estrogen and progesterone may be given continuously, continuous combined HRT, as we say, in those patients with postmenopausal and not have uterus. A small dose of estrogen. This regime normally results in about 90% not experience vaginal bleeding. Route of HRT administration, either oral or transdermal or small vaginal tablet, vaginal root ring with estrogen as contraceptive, cream, and this used for lubricant, and important in management of lower genital tract system. Progesterone in the form of levodopa is administered as an intrauterine releasing system, Mirena. This device not only provides contraception and control troublesome bleeding, but also provides endometrial protection for up to 5 years. Key benefit of HRT: symptom improvement such as vasomotor, sleep disturbance, performance during day, prevention of osteoporosis, increase of bone mineral density, and prevent cardiovascular dryness of our genital tract. Contraindication and potential side effects: absolute contraindication, those patients suspected of pregnancy, breast cancer, endometrial cancer, active liver disease, uncontrolled hypertension, patient liable for venous thromboembolic and non-hemophilic, and autosclerosis. Relative contraindication: uninvestigated abnormal uterine bleeding or undiagnosed uterine bleed of fibroid or myoma, past history of benign breast disease, unconfirmed personal history of strong family history of venous thromboembolic, chronic stable liver disease, and migraine with aura. Another risk factor for HRT cancer. The studies performed still do not fully inform patients of additional risk of they expose themselves to using HRT. Endometrial cancer and ovarian cancer are not considerably significant for developing cancer, and endometrial malignancy is largely eliminated if women are given progesterone. Cardiovascular and stroke increase in those patients develop menopause as early as possible, and most effect of HRT on the cardiovascular system when given to younger women are benefits, and however given to older women with effect may become deleterious and is likely to be higher in women taking combined HRT. Venous thromboembolism, HRT double the risk, and there is evidence of suggestive transdermal HRT through Its avoidance of effect on liver and may not have such great effect of bilateral incidence. The incidence of urinary tract infection also includes an incidence of episode of minor cystitis that can be accompanied of sexual activity. Thank you for listening.